Good morning. A very good morning to all. I am Dr. Aarti, and today at 6 we will be seeing about regional and transportational injuries. So we will start ahead. So regional injuries, whenever we talk about regional injuries, the main important part is given for the head injuries because they are very common, and identifying them is very important to all of us. Okay. So having that in mind, we will start with the external surface and then keep moving inside. So first is the skull, right? So the skull fractures. So in your exams, skull fracture images can be given, like for you guys to identify what type of fracture it is. Okay. Or they can also ask, like they can give you a fracture and they can ask what do you expect inside, right? So if you have a temporal bone injury, what do you expect inside in the extradural space or other spaces inside? Okay. So that's how we are going to see it also. So here you have a fracture, which is just nothing but a straight line, right? So it's called as the linear fracture. Okay, so when there's a straight line, only a line is there. Can you see this? This part, this is a linear line. It's called as a linear fracture. Now the same line, when it involves the suture, okay, it's called as the sutural fracture or diastatic fracture. Yes. So we have a linear fracture, the same fracture through the suture line. So here you can see it's between the frontal bone and the parietal bone. That's your coronal suture, right? So here it is there. Then you call it as diastatic or sutural fracture, right? And then you have the next part, which is comminuted fracture, right? So you have comminuted fracture. Yes. And then here you can see so here what happens is, what do you expect? It's kind of like a ring, right? Like a kind of a concentric waves that has happened. Now this happens when a broad surface comes and impacts, right? Over here, a broad surface and come and impact. Okay. It has happened over the parietal prominence or some prominence it has happened. So there's concentric waves. So it's also known as the concentric fracture. Right? So concentric waves have gone in. So it's called as the concentric fracture. Okay. The next type. Here, a depression has happened. It's called as the depressed fracture. Okay. Times the depressed fracture can mimic the weapon shape. Right? So when it mimics the weapon shape, it is known as the signature fracture. Yes, so here maybe a hammer, right? So it's like gone in like this. Maybe a hammer or any other round object has gone and impacted the skull, right? Okay, now similar to a depressed fracture, can you see over here? The whole segment has not gone in, but it's kind of like a pond, right? Now this is known as the pond fracture. And this is seen in children, particularly the infants. It's nothing but a green streak fracture, which happens in the skull, right? We study about green streak fracture in orthopedics, right? So same green streak fracture, when it happens in the skull is able to mold, okay? The inner table fractures, the outer table remains intact, okay? Or it happens that when it becomes a pond like this, here it might crack and here it might crack. But finally, when you see it on a CT or you see it live, it looks like a small pond which has happened in the skull. So it's seen in infants. It is also seen during the time of delivery if they have used forceps, right? So in forceps delivery also, we do get these kinds of finding. A pond fracture. What does it resemble? It resembles a keyhole, and it's known as a keyhole fracture. Where do you get it? Now, how does it look like? It looks like as if it's produced, it looks like a bullet, and it's also produced by a bullet. Okay. So here you have a fracture which looks like a keyhole, And in this case, it's also mimicking as if it's like a bullet, but it's produced by a bullet. Now, don't think that the bullet has gone and imprinted over here like that. Okay, what has happened is a bullet which is like this has just grazed through the surface. Okay, at one end it has entered, and at the other end it has exited, chipping off a part of the bone. Okay, so that's how we get the keyhole fracture. So sometimes instead of producing this classical shape like this or like a keyhole like this, it will produce just a removal of the outer surface of the skull alone. Like, so you have a skull like this. What it will do is it will just remove this part alone, right? Now, outer table of the skull alone is removed, and then when you see, it looks just like a gutter. So it's called as the gutter fracture. Okay. So the gutter fracture again is produced by a bullet, which just grazes through the outer table. That's all. Yes. So that's about the fractures of the surface of the skull, right? Vault of the skull. Now let's look at the base. In base, we get some types of fractures which are very, specific. Like we have this fracture, which is like a ring around the foramen magnum, and it's called as the ring fracture. And here you have another type of fracture where once, can you see this fracture line which has happened over here? Yes. So this fracture line which has happened over here, it will cause the brain to function like a hinge, right? The skull will now open out like a hinge. So it's known as the hinge fracture. When this happens at autopsy, after removing here also, you can see that there is a nice gap which is present, right? A gap which is present. When we have just tried to pull it, the nice gap has happened. This is known as the hinge fracture. Now, hinge fracture is of three types. Okay, the first type is where it goes from one petrous ridge to another petrous ridge. So here you have one petrous ridge to the another petrous ridge. This is type 1. Now, this type 1 fracture is seen most commonly in motorcyclists. Okay. So it's also known as the motorcyclist fracture. So when they hit the temporal bone and the fracture line starts from the one petrous to the other petrous. Okay, and it goes through the base where your pituitary sits, right? So in the pituitary fossa, it transfers the sphenoid bone also and goes through. Okay, so that's motorcyclist fracture. That's type 1. Now, the type 2 is where it goes from the posterior to the opposite side anterior cranial fossa. This becomes type 2. And the last type 3, which is seen in the anterior cranial fossa from one side to another side. Now, of this, the most common that we encounter is the motorcyclist fractures in road traffic accidents. We do get type 3 also, and then last is type 2 we get. Okay, so that's hinge fracture. Now, the ring fracture, very interesting, right? Like it forms around the foramen magnum. Yes. And now this ring fracture has some specific things. What is the specific thing about ring fracture is that, see, it's in the base. So how does a fracture happen over there, just around the foramen magnum? It happens in cases of fall, particularly, where the person lands on his foot or on his buttocks, and the force is transmitted along the spinal cord. Right? So here you have the spinal cord and the force is transmitted, the spinal cord just moves up. The whole vertebrae column moves up. Okay, so the whole vertebrae column moving up produces the ring fracture. So it's an indirect fracture. Right? Not the direct force which is happening, but the indirect force which is transmitting upwards. Okay. Also, in cases of assault, it has been reported that direct impact, if the person is like, sitting straight, and direct impact to the skull will produce the skull to move down the vertebral column. So again, there also ring fracture has been reported. Okay, now then some fractures to indicate the weapon. Okay, So here you have a fracture. So can you think what weapon could have caused this? Any guesses? You can put it in the chat box. What weapon do you think would have caused this? Okay, it's a chop. Okay, it's a chop injury. Yes, it has depressed and it has also pushed the part of the bone inside. Okay. So one of the questions that we expect or like is when we ask also, we ask is that like seeing this image, now let's say this is A and this is B. Which side do you think was the perpetrator standing or the accused was standing? Okay. So it's the side where the major part of the chunk of bone has gone inside, right? Like it's like this. If someone has hit him here, so the major part of the blow is taken up from the side where the perpetrator is standing in, right? So that side, the depth is much higher. So it's the B, which is the side the accused was standing in. Okay. Yeah. Now the last part where we get is known as the Pape's rule. Okay. Now what is this Pape's rule? You have two incidences which has happened. Okay. The person here has been shot with a nail gun, right? And then he has been pushed down. Yes, there's another explanation also that can happen. The person has fallen down during which the nail has gone inside. So we have to establish which has happened first, the nail first or the fall first, right? So in those cases, we apply a rule which is known as the Pape's rule. No, sorry, the Pape's rule. Now, what is this Pape's rule is that it states as simple as when there is already a first fracture line, okay, the second fracture line which is going cannot, or in general, the rule is that in general will not cross the first fracture. Reasonable, right? Physics. There is this fracture, already a space is there, another fracture line is going in, force gets lost. There is no more to move forward, right? So it doesn't extend. That's what they say. So now taking this into consideration, so I think you can see this part, right? So here you have one fracture line which is going, and here you have the other fracture line. So this is your first one and the second fracture line which has come and stopped over here, thereby explaining a Pape's rule. So it tells us like, which happened first, which blow happened first. Like in bullet injury, entry and exit has happened means, of course, we see the injuries, the whole also, and we see fracture lines which are transversing means which one happened, like which side fracture did not let the other one cross. So we do use it for those cases. Now we will come to our intracranial hemorrhages. So skull, we're done. We will revise again, like when we come to the end of it, but we'll go in for the intracranial hemorrhages. Now, intracranial hemorrhages. In live patients, you do get to see the CT, and seeing the CT, we have to interpret it. Whereas in dead patients, we do see the live images of. Okay, so we have intracranial hemorrhages which have happened, and the basic rule in understanding intracranial hemorrhages is that there are two types of forces. One is the direct force, right? The another thing that happens is acceleration and deceleration, right? Yes, one is the direct impact. There is a fracture, there is a rupture of the vessels inside, and there is a bleeding. Another thing is the acceleration, like the movement of the head moving front and back, the acceleration and deceleration causing the injury. It can also be a rotational trauma, right? Like the head getting twisted in any rotational way. Those can also produce injuries. Okay. To understand it, let's take our first hemorrhage. The first hemorrhage that we are going to see is extradural hemorrhage. They can give you an image and ask you to understand it. Now, when you see the meninges, here you can see the meninges. This part is the meninges. You're seeing the meninges and you're seeing the hemorrhage, which is above the meninges. Then it is extradural hemorrhage, right? The dura mater is there. Outside the dura mater, the hemorrhage has happened. It's happened between the skull and the dura. Then it's called as the extradural hemorrhage. So you have the extradural hemorrhage, right? Okay, now in the extradural hemorrhage, what all are we supposed to know? Okay. Vessel that is involved, right? Now, here you can see on the opposite side, these vessels which are transversing, right? These vessels which are branching in and coming and transversing, right? Over here, this part. Now, those vessels are known as the middle meningeal artery. Okay. Yes. So here you have these vessels which are transferring. Now, when there is a fracture of the skull, temporal bone, okay, when the temporal bone, which is like a fan like this, gets fractured over here, the underlying is the middle meningeal artery. The middle meningeal artery breaks and bleed. Now, again and again, let's insist on the word artery over here. The dura and the skull are like buddies. So the dura plus skull are like buddy. Buddy means best friends, right? Like they are like very close. And this friendship is stronger in children and in elderly, right? Yes. So they are very strong. They are strong even during the intermediate part of the life, but during childhood and old age, they are very strong. Now, why is this important to understand is that separate the dura and the skull and to cause a hemorrhage over here like this, right? So they're very close. You have to cause a hemorrhage like this. Some amount of arterial pressure is required. Okay, so that's why middle meningeal artery rupture produces this. Okay, so you have a hemorrhage which has happened like this. Now, this is biconvex, right? So it happens like this. Okay, so it's biconvex hemorrhage. It happens and it doesn't happen in ages below 2 years of age. And in very old people, more than 60 years of age, it's less likely to get it because the dura is really adherent to the skull. So in less than 2 years and more than 60 years, less likely. Yes. Okay. And we also saw the shape. Concavo-convex or convexo-concave, right? We can call it concavo-convex or convexo-concave. Okay. The hemorrhage has happened. There is something that we call in over here. What happens is a lucid interval. So what is this lucid interval? The person gets a head injury, right? He becomes unconscious. There's a concussion in the brain, he becomes unconscious. Then he gets up, starts walking, talking, does everything, and suddenly collapses and dies. Okay, so that's called as lucid interval. Lucid interval is the conscious period between two unconscious period. Now, the second unconscious period is why is it happening? See, initially he had a concussion. Then he woke up. He was walking around, nice, good. But the extradural hemorrhage, the arterial bleed is slowly happening over there. It is causing the separation of the skull and the dura mater. It is putting a pressure on the brain. Now, as the pressure on the brain increases, the brain tends to herniate. And as the herniation happens, the person becomes unconscious and dies. Now, this is very common. And that's why we say head injury cases, we need to observe the patient at least for 24 hours. It is also said that, like, you take a CT in the beginning and you again take a CT at 6 or 12 hours to check whether the EDH is progressing or is there any EDH that is newly developing. It is also portrayed, it's very commonly portrayed in many movies also. Like, so if you're a movie person, like you would have seen it in multiple movies where like a hero gets injured, he walks, he helps around, and then again, like after sometimes he collapses and dies, or he or she collapses and dies. So that's extradural hemorrhage. So in extradural hemorrhage, you have the middle meningeal artery which has involved. The age group less than 2 and more than 60, it is less likely to be caught. And you have a convexo-concave kind of a hemorrhage which is there. In CT, which you see, whereas in when we do the autopsy, we almost see it like a pancake-like appearance. And you have a lucid interval, right? The lucid interval is where the patient is conscious between two unconscious period. Yes? Okay. The next thing that we are going to see is the hemorrhage which happens below the dura mater. right, below the dura mater. So here we call it as subdural. Okay, so this is the hemorrhage which has happened. Here you cannot see the blood, but you can see the dura, and this dura being slightly transparent is showing that below it there is some purple color hemorrhage. Okay, so there's a purple color hemorrhage. Now, when we dissect it, it generally goes off. The blood comes out immediately. Okay, so that's subdural hemorrhage. It's below the dura, above the arachnoid matter. So when the brain is removed and we pour water, or when during the process of removing the brain, only the subdural hemorrhage gets washed away. Okay, so what vessel causes this hemorrhage? Now, here the hemorrhage happens because of the vessel, which is the bridging vessels. Okay, now what is this bridging vessel? Now, this bridging vessel is nothing but you have the superior sagittal sinuses, right? So sagittal sinuses are there. And then above the brain, you have the superficial cortical vessels, right? Now, these veins will drain into the superior sagittal sinus. Now, these are known as the bridging vessels. Okay. This vessel will break when there is acceleration, deceleration trauma, or a rotational force. So when the skull is moving like this and this vessel is like hanging here, it keeps moving here and there, and finally it will snap off. Okay, so that's subdural hemorrhage. Due to acceleration, deceleration, trauma, we get subdural hemorrhage. Okay, whereas extradural, it predominantly or most of the cases happens due to direct trauma, and 80% to 90% has an associated fracture. Whereas in subdural hemorrhage, there might not be even a fracture, just an acceleration, deceleration trauma causing bridging vessels to break. Now, when will these vessels break? Of course, old age. It breaks. Why? In old age, the brain has atrophied. Okay, so the vessels have got elongated. At the same time, due to atherosclerosis, the vessels have also gained some amount of stiffness, right? So they tend to break easily during this time, right? Now, the special feature over here. Now, the special feature over here is this subdural hemorrhage can go in for chronic hemorrhage also. Okay, so we can have an acute subdural hemorrhage, or we can have a subacute when it's more than 3 weeks, or when it's more than 3 months, we call it as chronic subdural hemorrhage. Okay, so you have chronic SDH, subdural hemorrhage. Now, when there is a chronic hemorrhage that's happening, the arachnoid gets irritated, right? It's like, okay, there's a constant blood that is there. It gets irritated and it tries to encapsulate the hemorrhage. So here you can see the second image where the whole hemorrhage has become encapsulated, right? It forms a new membrane. It forms a new membrane and tries to encapsulate it. Later, even the lower membrane will look similar to the dura mater. So it will look as if the dura mater has completely covered it up. So you get in chronic subdural hemorrhage, neomembrane formation. Yes. Sometimes within this capsule, repeated bleeds can happen. Particularly in alcoholics, we do get this. They fall, they get up, they are continuously doing good, fine, everything is fine. Small affecting their, small work, they don't worry about it, carry on with their life. Again, drunk, falls again, gets up, drunk, falls again, gets up. It keeps on happening. So they get repeated bleed inside the chronic subdural hemorrhage itself. Okay, so here you can see this, the chronic subdural hemorrhage. So what shape does it take? Here you have a, here you have a concavo convex kind of a bleed. And here you have a biconvex. Yes. Okay, I'm sorry for that. Here you have a hemorrhage which has split like a lens, and here you have a hemorrhage which has like a tawa, right? Or inverted tawa, right? Okay. The next part of the hemorrhage. So we have finished a hemorrhage which is above the dura, and then we finished a hemorrhage below the dura, and the last part is in the subarachnoid space, right? So we have a subarachnoid hemorrhage. Right? Now, subarachnoid hemorrhage is very common in trauma. Most of our trauma cases will have like a small amount of subarachnoid hemorrhage, and that hemorrhage is because of superficial cerebral vessels bleeding. Whether it's a direct trauma or an indirect trauma, like some amount of superficial cerebral vessels which are there, they are not supported well. So some amount of bleeding happens over there. Okay. But the significant amount of bleeding, or like the cause of death kind of a bleeding, happens when there is a rupture of berry-aneurysm. So here you can see a small aneurysm which is present there, right? Berry-aneurysm. In anatomy, we do study that. It's common in the anterior communicating circles of the circle of Willis, right? So in the circle of Willis, anterior part, mainly between the anterior communicating artery and the anterior cerebral artery, we do get these bridging vessels. Now this here, the aneurysm is at the bifurcation of the internal carotid artery. Okay. Okay, so here you have the superficial cerebral vessels in trauma which has ruptured, or the berry aneurysm which has ruptured. Okay. Now this berry aneurysm, when it has ruptured, it fills in the base. So here you can see the base of the brain, right? It's fully covered with blood, and when we pour water, it doesn't get washed away because it's below the arachnoid matter. So we have to dissect it slowly and remove. Underwater dissection we do to check for the aneurysm, right? So here you have the berry aneurysm which has ruptured. Okay, so what is this important about this subarachnoid hemorrhage? Of course, the subarachnoid space is place where the CSF is there, right? So when there is let's say the patient presents with head injury and CSF taping is done, then we get xanthochromia. If there is only a small amount of bleed that has happened and the person has survived, then xanthochromia is received. Yellowish discoloration. Discoloration of the CSF, xanthochromia. We do get that, right? And in CT, we will be seeing it that it is filling all the sulci also in the brain. It fills the sulci. Yes. So here you have this hemorrhage, subarachnoid hemorrhage. It doesn't get washed away. Most of the trauma cases will have it, irrespective of the age, whereas aneurysm, it is said during the adulthood that it ruptures, right? Okay, so those are the three hemorrhages. Extradural hemorrhage, again, let me clarify it, it's biconvex, whereas subdural is concavo-convex. Yes, the next, we have come to the brain part, right? So in brain, we start getting cortical contusions and brain hemorrhages, right? So the cortical contusions. When there is a direct trauma, like here you have, the person has been hit with a wood, there is a direct trauma, and just at the site of the injury, when there is a contusion in the brain, bleeding in the brain, then that is cortical contusion. We call it as the Coop injury. Okay, so it's a direct, same site. Yes, but when the force has happened in the opposite side, that is, the person has fallen back. Okay, so the head has hit the floor. The skull is falling down. Law of physics, the brain is also falling. The skull comes to a sudden halt, right? But the brain has still not. So it hits the anterior part, or when it is, the brain is moving back, sudden stoppage, the skull has stopped, the brain is moving back. The negative effect, the negative force creates a vacuum and causes rupture of the blood vessels over there. So the fall or the trauma has happened here, but the hemorrhage on the opposite side, right? That's called as the countercoup injury. Right? So coup injury, direct, countercoup, of course, counter means opposite side. Opposite side hemorrhage when you get, it's called as the countercoup injury. Now these brain, whenever there is a bleed or a small amount of trauma or anything, they will undergo scar, which is known as the gliosis, which happens, right? Now, gliosis is what happens in the brain, and that engross to us gives an image like this. So can you see this is the normal gray matter? Whereas here, right, in the caudate nucleus, the color has changed over here. And also in some part of the corpus callosum, which connects both the cerebral hemisphere, we can see this white matter is so showing some grayish discoloration. Now that's gliosis. Now, the older injuries becomes interesting to us in particularly cases where there is a sports or any exposure to repeated trauma. So that's where we get punch drunk syndrome or the boxers syndrome, right? So what happens in boxers? Repeated head injury, right? If you've seen this Will Smith's movie, Concussion, football players, right? They get repeated head injuries. And because of that, small amount of gliosis keeps happening continuously through their life, but will present later in their life, okay, with different abnormalities like memory loss or the gait altered or different features based on the site of the gliosis. So what do we get it? When we get, there is atrophy of the brain, not justifying with the age, particularly decrease in the white matter. Now, this decrease in white matter resulting in increase in the ventricular space. Right? So the decrease in white matter resulting in ventricular space being expanded and gliosis. Either we can see it grossly itself or in microscope we see it. And this is mainly seen in and around the basal ganglion region. It affects the basal ganglion region. Okay. So the gray matter of the basal ganglia, the white matter of the cerebral hemisphere, along with increase in the ventricular space. We could call it as the punch drunk syndrome. So he will resemble as if like he's always drunk, the gait is altered, irritability or different features comes in. And this is seen in boxers. Okay. No, intracerebral hemorrhage where the bleeding has happened. Now, here you have two images, right? So here you can see there is multiple hemorrhage over here. It's a different color. Yeah. So you have hemorrhages over here, hemorrhages over here, hemorrhages over here, right? And here you have another hemorrhage which has happened at one point, right? So these two images are given. Generally, in general, when you get multiple hemorrhages in the brain at different spots, different shapes, right, it tends to be traumatic. Okay, until and unless the patient has a metastasis or other viral infections related things, it tends to be traumatic. Whereas a single bleed, large bleed near the basal ganglion region, whether it's in your CT or it's in a gross image, it tends to be spontaneous. Right? So the spontaneous bleeds happen in all the regions which you will be studying for hypertensive bleeds, like the basal ganglion. So here you can see it. It has happened just at the junction of the internal capsule and the globus pallidus and putamen area where it has bleeded, right? The internal capsule is one of the most common area to start bleeding, right? So here it has happened, or you might get it in the pons. The other common site we do get is in the pons. So those regions you have to look for. So if it's a spontaneous bleeding, it's generally one. Whereas when you get a traumatic bleed, it's multiple. There will be like cortical bleeds. There will be bleeds again near the basal ganglion region, external capsule region, and all these kinds of things. Okay. So here you have these bleedings. Now let's see what are these bleedings. This is known as the diffuse axonal injury. Diffuse axonal injury. Okay. Now, this diffuse axonal injury, it's because like the brain is moving, there's some amount of acceleration, deceleration trauma. The gray matter is at one consistency and the white matter is at one consistency. So they move at a different space, right? It's like a plate and a jelly. You move the jelly top part will move at a different pace. The point where it's in contact with the plate will move at a different pace. So when they are moving like that, the vessels between them gets ruptured. So here you get to have ruptures. It also happens in rotational trauma where the two cerebral cortex move at a different pace, right? So the corpus callosum, the intermediate structures and everything gets ruptured. All the anterior commissure, posterior commissure, the corpus callosum, they all tend to show hemorrhages. So that's diffuse axonal injury. Now see, axon is a microscopic structure, right? So we cannot see axon. So what do we see? These axons are associated with blood vessels also. So what do we get to see is diffuse vascular injury. Grossly, what we see actually is the vascular injury I'm seeing. I'm not saying it's a axonal injury, but when there is when there is diffuse vascular injury, there is an associated diffuse axonal injury. Okay, so that's how we get it. Okay, so there's a diffuse axonal injury in this case. So here you can see again between the gray matter and the white matter, the bleeding has happened. So it happens between gray, white matter junction in the cortex, okay, cortical, or it happens in the corpus callosum, okay, or it can happen in the brainstem. Depending on the site, the severity also varies. Of course, in the brainstem, the severity is going to be at a much higher range. It's also known as the gliding hemorrhage or the sliding hemorrhage because it's happening because of those movements. And the hemorrhage is generally slit-like. So when they use the word slit, S-L-I-T, it's diffuse axonal injury. So here you can see it's like a slit which has happened, small crack which has happened over here. So that's diffuse axonal injury. So the diffuse axonal injury can be seen when they give an image like this, either in CT or in gross, and they ask you it's diffuse axonal injury, though in gross we are seeing bleeding of the vessels. Okay, so they happen at the gray white matter junction, corpus callosum, and brain stem. Okay. Now here you can see this corpus callosum which is here, right? The corpus callosum which is here is showing multiple petechiae, right? Now this multiple petechiae all across, there is no much cortical hemorrhages, right? Then this multiple petechiae is seen. So see the difference between the previous image and this image. The previous image is not having hemorrhages in all these regions at all. It's having like the places where the the force has happened more or the vessels have been light, it has ruptured. Whereas here you can see diffusely all across it has happened, the hemorrhage has happened. Now this multiple petechial hemorrhage is seen in fat embolism. So in fat embolism, in general, they will give you a history. They will give you a history where the person had a fracture or something like that of a long bone, and then he was fine. He suddenly started developing CNS symptoms, not pulmonary symptoms, but CNS symptoms, and died. Right? It can also happen during liposuction surgeries or any other surgery which involves fat or surgery which involves prolonged duration of time. So those cases, fat embolism is seen. Systemic embolism. Okay, it's not that the fat from one part is going across. It's mainly because the fat which is already suspended in our blood vessels starts to conglomerate. It all starts to fuse between each other. Okay, so we get this fat embolism. Again, multiple hemorrhages are seen. Now here the histology becomes important. Histopathology. When we see in histopathology just a H&E staining, what do we get is there is this nice blood vessel in which the red blood cells are pushed to the corner and there is a halo in the center. Now, in few vessels would have ruptured out and that's why these hemorrhages are seen. There's a halo or an empty space. Why? In H&E, a normal H&E stain cannot stain the fat, right? So the fat is just seen as a vacuum, empty space. So you get a vessel in which the blood vessels is pushed, or you get sometimes when you get the blood vessels like this, a beaded appearance where the red blood cells are all here, but there's a halo over here. Those is because of fat embolism. Okay. Now this is seen histopathologically. Yes. Now we want to see it using special stain. Of course, special stain you will be using Sudan or oil red oak. Right. So these are the stains which you will be doing. Now the same when you see in diffuse axonal injury, histological examination, that Axons are there, like these are the axons which are running around. They have been traumatized. They will form a bulb like this. They will retract and they will form a bulb like this. Because all the materials which are flowing through the axons have all now joined in together at one place. So in cut section, we see something called as the retraction bulb or balls, we call it as retraction balls. Here, to see this, we need the person to survive. Spot dead, we don't get it. Why we need the person to survive? See, the trauma has happened. There is a stick. The trauma has happened. Now, all the materials have to accumulate, right? So the accumulation takes some time. So for it to accumulate and form a ball, it takes some time. So it takes, few literature says 6, few literature says 12 hours. So minimum 12 hours at least is required for that retraction balls to be seen. It also depends on the stain that you use. If you use some stain like specifically you're looking for amyloid protein, which goes through the brain, right, axons, then it can be seen as early as 2 to 6 hours also. Okay, but if you see a HNE staining, 12 to 24 hours is required. So brain herniation. Now the hemorrhage has happened, brain herniation. We'll go in a simple revision, like because you would have studied brain herniation at many places. So first is the Monro-Clennon doctrine, right? So the doctrine is mainly talks about the intracranial pressure being maintained by the brain matter, the volume of the brain matter, the volume of the CSF, and the volume of the blood at any time needs to be commemorated together. Altogether should be a constant. Then only the cavity can accommodate, right? The skull cannot expand or close or anything. So that's the thing. The next, whenever there is the intracranial hemorrhages happen or the intracranial pressure increases, we get something called as Cushing triad, right? Now, what happens in kind of a Cushing triad? The brain is saying there's no blood. So the systolic blood pressure increases. Okay, so the heart says, okay, let's pump in more blood and everything. So the systolic blood pressure increases. There is a widened pulse pressure. So you get wide pulse pressure. Yes. And of course, this results in bradycardia. And of course, irregular respiration. Right? So you get that Cushing triad. Now, once the hemorrhage has happened and the bleeding is happening slowly, the brain matter starts to herniate. So what is this hemorrhage that's shown over here? Okay, it's a biconvex. So it's a extradural hemorrhage which has happened over here. You tend to get herniation, right? The brain matter is herniating. So one of the most common herniation that we do see is uncal. So the first that is marked over here is the uncal herniation. The second is known as the downward transtentorial. Okay, downward transtentorial. Okay. The third is falx cerebri is here. So subfalcine. Okay. The third. The fourth, the cranial matter, the skull is there. Through the skull, it's going out. It's known as transcranial. The fifth is again between the tentorium only, it's herniating, but it's going upward. So it's upward transtentorial. And the last one, where the brainstem tends to move down, is the when the brainstem starts to move down, what we do see generally is the tonsils of the cerebellum gets moving down, right? So that's known as tonsillar. Okay. So that completes our herniation. So herniation, it's just a revision. You would have studied at multiple places. Whenever there's a hemorrhage, there seems to be few herniations which happen. So here, can you see the hemorrhage, the herniation that has happened? So here the patient has had a trauma. For releasing the pressure and removing the blood which is collected over there, they have done a craniotomy. Okay, so they've removed a part of the skull bone over here, and through the craniotomy wound, the herniation has happened here. So that's transcranial. Okay. The next that has happened is over here. Here you can see that this is the upper part of the cerebellum. So upper part of the cerebellum, upward transtentorial. Okay, so when you're seeing the cerebellum, just see whether you're seeing the tonsillar region, lower part or the upper part. If it's the upper part where the vermix is getting herniated, it's upward transtentorial. Now here, this is a fixed specimen. The arrow number 1 is showing the uncal herniation, right? You see what happens in uncal herniation. Here you have the tentorium, which is like this, and one side of the brain is herniating like this, right? What happens is that it pushes the brain stem to impinge on this structure over, or the tentorium on the other side. Okay, so it pushes it to get notched over here. And finally, after some point, what happens is this one also will develop a notch. So the brain stem will develop a notch like this. And that is known as the Kernohan's notch. Okay. Okay. Now, this notch will be there grossly, or it can be also seen in the CT images. Now, this all causes stretching of blood vessels also. So there will be hemorrhage in the brainstem. Okay, hemorrhage in the brainstem. Which is known as the Duret's hemorrhage. Okay. So here you have the uncal herniation. The uncus is herniating. As the uncus is herniating, it's pushing the brainstem to go and impinge on the tentorium on the opposite side. So the brainstem gets flexed, thereby producing a notch, which is known as the Kernohan's notch, and there's going to be bleeding into the brainstem, which is known as the Duret's hemorrhage. Okay. So that finishes the brain or the central nervous system completely. Let's go into the other structures which are involved. So you have the heart, right? Now in the heart, blunt force trauma, to the heart or the chest region, right? In chest only we get the blunt force trauma, results in sudden arrhythmia or sudden collapse of the patient. That's commotio cordis. Just a trauma to the chest. That's all. It's trauma. The heart goes in for a sudden concussion like state. It just freezes. That's all. Or it goes in for a arrhythmia. So that's commotio cordis, right? And then you have the cardiac tamponade. Of course, when there is a rupture due to a trauma or due to a myocardial infarction, you get a cardiac tamponade. Cardiac tamponade is nothing but the hemorrhage that is going to collect in the pericardium, right? So the whole pericardium is going to get filled with blood. The heart is not going to be able to pump anymore, thereby getting a Beck striate. So what is this Beck striate? So it's seen in pericardial bleed. Now the Beck striate has 3 components. So the hemorrhage has happened. The heart is not able to expand fully. Venous return is not happening. So you're going to get increased JVP, right? Increased JVP. On the sides, you can see the JVP has increased on both sides. There's going to be a fall in BP. So there's no venous return, nothing to go out also. And the heart sound is going to be diminished, right? Muffled heart sound. So that's Beck's trend. Then the spinal cord. What happens to the spinal cord in case of trauma? Again, acceleration, deceleration trauma, right? Right? The front and backward movement causing a whiplash injury. We call it as the whiplash injury. So that's why if you see like in fast car racers and everything, they stabilize even the headband is put. They stabilize the brain. the skull, so that no movement, acceleration, deceleration trauma happens, right? But that's going to be uncomfortable for routine driving, and we don't go at such high speed. But anyway, in highways, when high speed vehicle clashes, there's going to be acceleration, deceleration trauma, which results in whiplash injury. Okay, now this whiplash injury can be in different ranges, but at times we do get fracture of the cervical vertebrae also. The upper ones, C3, C2, they get fracture. So sometimes fracture of cervical spine is also seen. Okay, next is concussion spine or railway spine. So it's called as railway spine because in the earlier time it was seen mainly in the railway accident cases, but now even in road traffic accident cases, fall and other cases happens. So when the person meets with an accident, need not be a very big accident also, the acceleration, deceleration for trauma causes sudden concussion to the spinal cord. Okay, even a sudden bang, right? Like the person gets hit suddenly, sudden jerk to the spine, and there is concussion to the spine. It's a temporary thing, a small amount of paralysis which will disappear, or a small amount of pain which will disappear later on. It's a temporary feature. So those are the terms which we should remember. Commotio cordis. See, commotio cordis, though the name is cordis, it's in the heart. So be very clear about this. Whereas in the spinal cord, we call it concussio spine. We call it directly itself as spine. Okay, concussio spine. Okay. Now, the next we will see is the road traffic accident. Very simple, very easy, right? Here you can see it. I think most of you would have seen this movie also. It's from the movie Raja Rani. Anyway, so they have depicted that injuries which happen in a very nice way. So that's why I've taken the image from that. So here you can see the vehicle comes and hits, right? It hits the leg. The bumper hits. So we get bumper fracture, primary fracture. In adults, it happens either in the tibia or in the femur, depending on the height of the vehicle, right? The next, after this is the primary impact, the secondary impact here, the secondary impact happens when they hit the bonnet, right? Here the chest and the head gets injured, secondary impact. The tertiary impact or just the plain secondary injury, the person is thrown onto the road, thrown. Road. Okay. Now, when they are hitting the road, any type of injuries can happen again, but predominantly it is head or the chest or even the pelvis. Okay. Back, any part. Okay. They all can get injured. Now, after this, if the person sometime is lying on the road, run over injury can also happen. At times, they need not be lifted and thrown up and all. Just the run over injury can happen. Now, this run over injury is more common in children. Now, why is this run over injury is more common in children? Is because, see, in the adults, the center of gravity is slightly higher. So they tend to be lifted up, right? There's a structure here, they tend to be lifted up. Whereas in children, the center of gravity is low. So when they're knocked, they fall down just like that. Okay. So the child who is a pedestrian, children pedestrian running across on one side, they tend to get the Waddell's triad. Now, this triad is very easy. See, in children's, again, they are very small. The femur gets injured. Okay. And then the chest get injured on the same side, right? The same side, femur, chest get injured. The child falls down and the head injury is on the opposite side. On the opposite side. Okay. So that's Waddell's triad. Okay. Now, the other fracture which can happen or other injuries that we do get is so this is a normal accident which has happened where the person has been unrestrained injuries. Unrestrained means the person who has not worn the seatbelt tend to have more injuries. They can hit the steering wheel, they can hit the front screen, the glass, and they can hit any part. Okay, they can even be ejected. Once they are ejected, the chances of survival becomes lower and lower. Okay, and here you have these injuries. Can you see this? Small injuries which have happened over here, right? Now these are called as sparrow foot injury, and this sparrow foot injury is mainly because of glass particles. See, the side glasses breaks and they are produced in a way that they crumble down so that they don't penetrate. At the same time, the person can also escape, right? So the side glass, when it breaks, it produces this sparrow foot injury. Now, from this, why is this important to us? We will be able to see whether the person is a driver or the side seat person. Okay, whether the person was sitting on the side or he was the driver. Okay, so in this case, he was the driver. So here, all the glasses have caused injury on him. Okay, now next is the seat belt injury. Now, the seat belt injury produces a triad. Here you can see it, right? Like this lap belt. Now, the lap belt predominantly causes abdominal wall injury. And of course, inside you have major blood vessels, right? The aorta can rupture off. Injury. And of course, then you have hollow structure, or small intestine, large intestine, stomach, right? The hollow structure injury. That's it. Seatbelt triad. Next, airbag, right? Just like a slap on the face. That's all. Okay. The airbag, if it contains the logo and all, it produces the mark of it, and it's just like a slap, right? So an airbag will produce a slap. The next here, it is the steering wheel, right? The steering wheel. The logo is there, the logo gets imprinted. When the steering wheel hits, there can be multiple fractures of the face, the chest, whichever part comes and hits the steering wheel will have those marks on it. Okay, the motorcyclist. So the motorcyclist can get any kind of injury. There is nothing specific that they will get this injury or this is what is expected. Anything is and everything is seen. We've already seen the motorcyclist fracture, which is nothing but the hinge fracture. Right? The base of skull, we saw that from one pictures to another pictures. Now, the other thing that's seen is the tailgating. So what is this tailgating is that there's a truck which is standing and it doesn't have the proper lights at night. They go and, hit the truck from behind. So the truck end is like this with the wheel down means the biker will go and slide down inside. Okay. Sometimes his head will be like stuck over here. The rest of the vehicle will go down. So that's called as tailgating. So from the back of generally a heavy vehicle, truck mainly. So when they go and hit that, that's called as tailgating. So anything and everything can happen. The last part, today's class, alcohol and road traffic accident. Now, as per the Motor Vehicle Act, in India, up to 30 milligram per deciliter of our blood is allowed. So 30 is the limit. Okay. So in blood alcohol concentration, up to 30 is allowed. See, that's because zero we don't have, few countries have it, just because of the fact that when it is zero, like alcoholic and all, they have they can produce, sorry, not alcoholic, diabetics, right? So diabetics can produce some amount of alcohol in their body. So that's why we don't have that zero policy. We have 30. So above 30, it's not allowed. Okay, so that's our whole regional and transportational injury. So we'll just revise it, the small case over here. So here is a person who met with an accident and there are 4 images given. See all the 4 images. Do not get stuck with one image. Particularly, I want you to pay attention when images are given like this. Here you have a fracture and always see which side it is, right or left. Okay, you are seeing the patient. You're seeing the patient from this. So this becomes the right and this becomes the left side of the patient. So left side base is also fractured. Okay. So now let's try to answer all the questions. Black eye in this case is due to, so there's some amount of black eye which has happened over here. So black eye, the contusion in the eyes are due to this fracture, anterior cranial fossa fracture, right? Now, what is the type of fracture that we are seeing over here? We are seeing a linear fracture, right? So we are seeing a linear fracture which has come, and over one more here. So it's a linear. Now, lucid interval is in this case. How can you explain? So there's a fracture, lucid interval, EDH, extradural hemorrhage, right? The last two questions, which type of cortical contusion have we got over here? Now, see, here you have the brain. Now, if they would have given the label in most of the cases, so this is the right side of the brain which we are seeing. So here you have the skull, the left side of the skull, the left side of the skull is fractured, whereas the right side you are getting hemorrhage, it's counter cool, right? The site of Durett's hemorrhage. So when there is an intracranial pressure that's expanding, the uncus gets herniated, thereby Durett's hemorrhage can happen in the brain stem, right? So that's a regional and transportational injury. So we have seen the types of fracture and we have seen the hemorrhages. Dr. Sharon? Okay, I think Sharon sir is not there. So if you have any questions, you can drop it in the chat box. Do you have any questions? Okay, thank you all for joining us in the morning. And please do revise through it. It's a very simple topic, but a good amount of question is asked from this topic, the regional injuries. Okay, so do revise through it. Thank you all. Okay, I have a few questions over here. EDH is biconvex. Okay, and that's it. Okay, thank you all.